So I'm here to talk about coronary perforations in CHIP, but most of these complications I'm going to show you are from CTOs, because that's all I have. But anyway, it qualifies as CHIP. So this is a brief introduction to what we do. We have a CTO, Center of Excellence, where we conduct training on a monthly basis for young cardiologists. And we do about 100 to 120 cases a month, which dipped during COVID to terrible numbers a year. And success rates have been above 95 of late. And the reason why I showed this number is that you can see here that the MACE rate and the success rate, they directly relate to your numbers per year. So there are so many complications that happen during complex procedures. Perforation, rupture, ischemia, device, bleeds, and today we'll deal only about perforations and ruptures. There are some modifiable and non-modifiable risk factors. The non-modifiable ones, of course, the age, gender, and previous CABG and use of clopidogrel. The modifiable, some peripheral vascular disease, congestive heart failure, you can treat for some time. So these things usually can be overcome with some effort. But the coronary risk factors, you really can't do much about it. And the calcified lesions, hydrophilic wires, penetrating wires, and epicardial collaterals are the most common reasons. And the only thing we worry about perforation is the tamponade. Other than tamponade, there is nothing else to really worry about except probably a big septal hematoma. And this remains our biggest pain when it comes to CTO-PCI. So if you see this illustration of pericardium over the myocardium and the blood vessel wall here, some of these perforations can just remain subserosal. And that is when you see a contained stain which remains in the same place for a long time. And usually those are not problematic. And of course, we all know this various types. So now we have a type 5, which is a wire perforation. So usually you can see that a small balloon inflation would help for some time. If it's a small perforation and if you reversed anticoagulation, then probably it may seal by itself. But the larger ones usually need a covered stent and pericardiocentesis. And type 4 is rupture into vessels, cavity spaces, which usually don't need treatment. Now, if you look at the various things that have been used to treat perforations, the smaller release ones usually don't need anything. Once you give prolonged balloon dilatation and reversal and nothing, no treatment. As the severity increases, you can see that more and more devices are required and pericardiocentesis is quite often required. But I think the need for surgery these days is much less, unless in structural cases. So wire perforation can be the vessel wall, a distal branch, or a collateral. So this was an RCA CTO. I tried attempting it from antegrade with a Miracle 6. It looked okay, but that stain remained there. Then I took a different projection and you can see how grossly off it was from the target. But this case, eventually we finished retrograde and you can see that that stain has gone and there is no leak. So usually when you perforate inside the CTO segment, it's usually an oblique track and usually seals off with a stent. And the distal branch perforations, when it is contained and remains that way, you can actually leave it, but you have to be a little cautious and you have to keep monitoring it with the echo. If it bleeds into pericardium, most often it leads to tamponade. This was a case where of wire perforation, again in the RCA CTO. The wire position looked quite promising initially, but then it was totally off when I injected through the microcatheter because I knew quite surely that it was off. And you can see the stain along the pericardial surface. But once we came retrograde and revascularized the whole thing, The stain remains constant there. So it's not a big deal after that. Of course, we monitor them overnight. This was a strange case, 32-year-old guy with a severe heart failure, refractory heart failure, and could not be operated. And then we revascularized with 8 stents. He's an interesting case because all the major branches were flowing and all his side branches were occluded. So he had a CTO of the circumflex, the ramus, bar OM, all 3 diagonals, distal LAD and PDA PLV. So there was no chance of surgery, and so I also didn't know much of what to do because the diagonals could not be seen initially. Then if I put 2.25 stents, about 8 stents totally, and immediately he improved. Within a few hours, his pressures were better. But the mistake I made was here. There was a small distal perforation. And I thought this constant staying there, contained one. So I shifted him back. The next morning, he had a pericardial effusion with tamponade. So we did a pericardiocentesis and removed the fluid and removed the guide catheter also. Then shifted him to the ward ready for discharge, developed a pulmonary embolism, which was quite significant. So I was not sure what to do, because heparin, he was little more than RV was dilated, dysfunctional. He was already sick. So I thought we'll try a low dose of streptokinase. We started, and another 6 hours later, he had another tamponade. So, and that was quite bad. So I had to do a pericardiocentesis in the CCU. But I had a small doubt, so I checked. The needle was, the sheath was inside the LV. But luckily this time, because it was the second pericardiocentesis, I had taken the, long Venflon-like thing that anesthetists use. So luckily that was the only thing in the LV. So I left it there. We took him back to the cath lab. We again did a dry tap, put a pericardial sheath, and then removed this needle. It bled for a few hours and then stopped. And the patient has improved. His EF is now 40. So distal perforations, coils can be delivered through microcatheters, usually 0.8, and coil sizes can vary. Microspheres and fat also can be used. These are the few microcoils available: Azure Systems, Concerto, and Axiom coils. Axiom is a detachable coil, so you can reposition it multiple times. Microspheres available in various sizes. Has to go through an OTW, cannot directly go through the microcatheter. Or you'll have to jail the microcatheter with another balloon, but still sometimes it can leak back. Thrombin can be used, but a little more dangerous than the microemboli because the thrombin can track backwards and create more problems. I use the floppy part of the regular guide wire. What I do is I take it and coil it over the puncture needle to make an irregular shape. Otherwise, it takes off into the pericardium. That has happened once. We coiled it, it stopped. And the tamponade, when you do fluoro, there is a 3 centimeter wire flying around. Coronary rupture is, of course, the most dramatic that happens, which needs immediate action. And all of us are familiar with covered stents. We can use the same guide catheter, or we can bring a second guide catheter to seal the perforation. But covered stents are not without challenges. You usually need a guidezilla or a tracker to take it down. This patient actually started bleeding. You can see the small track going there. Then it was actually a rupture into the LV. But I was not sure what that intermediate shape was. There was a small cloud in before that, and I didn't have the courage to leave it like that. So anyway, I put a guidezilla and put a covered stent. This went off very easily. But there are some times when this was a strange case, post-CABG with a distal OM1 disease actually. But the bend of the OM had so much calcium, and at that time our rota, something was not right. So I had to anchor and pushed. Actually what happened was the shaft of the balloon flexed at the junction just after circumflex and cut the vessel. So you can see it was a big bleed. and nothing would go. So I had to actually dilate it after that and put a stent from left main to circumflex. After the stent, again, stented the lower part also. Then took the guidezilla. Then had a lot of difficulty with the covered stent going through the guidezilla. It didn't go. So I had to literally force it through that. You can see that I'm pulling the guidezilla back to push this. It went. But by the time it reached the lesion, the balloon had punctured. So I had the covered stent at the lesion, but it wouldn't inflate. So I had to take it back, then re-wrap it in another balloon, and finally delivered it, and went off well. So this we had this discussion earlier that which covered stent goes through the guidezilla.
Dr. Anand, if you could wind up.
Yeah, I'm finishing. Papyrus is probably the most trackable. There are some strange techniques that people have described, but I'm not sure how possible it is to create a subintimal space and then stent that to cover the perforation. You can do that even retrograde to cover the perforated area. If it doesn't, then you'll have to use a covered stent. So take-home messages: wire perforations you can watch. Distal perforations have to be monitored very carefully. Best is to coil it. Disappearing perforations stains are usually very dangerous. Of course, frank rupture, please auto-transfuse. It really helps. And we have had patients who had ruptures. We've immediately put the covered stent. No bleed after that, but hypotension was refractory, and they had formed thrombus in the other segment with the left system. And again, we had to thrombolize. Patient somehow survived because, anyway, that's the only option that was left. So we have to be watchful of the other options that can happen when you have a tamponade. Thank you.